Hello, I am Dr. Kenneth Cusi. I'm a professor of medicine in the diabetes division at the University of Florida. And it is my pleasure within this Pan-NASH initiative to share with you the latest update by the American Diabetes Association regarding the standards of care for the diagnosis of management of non-alcoholic fatty liver disease. An important aspect of the guidelines is to help clinicians risk stratify people with prediabetes or diabetes. As such, in this call to action by the American Diabetes Association, the first recommendation is that adults with type 2 diabetes or prediabetes, particularly those with obesity and cardiometabolic risk factors, should be screened and risk stratified for NAFLD, particularly in search of those with clinically significant fibrosis. Clinically significant fibrosis are those who are at the highest risk of developing cirrhosis, and we'll talk about that in a moment. How we're going to do this is based on the calculated Fibrosis 4 Index or FIB-4 Index, which many of you know is an equation that derives from combining age, AST, ALT, and platelets. And this should be done even if the patient has normal liver enzymes. Now, an aspect that's really important is for those who are non-hepatologists to define what clinically significant fibrosis means and why that's an important target of our screening. It includes stages 2, 3, and 4. So for those who are not hepatologists, in the histopathology analysis of any liver biopsy, you can have no fibrosis, which would be F0. You can have cirrhosis at the other end, which is F4. And then you can have mild fibrosis, which would be mild, considered when it is F1. F2 would be moderate, and F3 would be advanced fibrosis. The reason why we emphasize stages 2, 3, and 4 is because this group has been clearly associated with a progression of disease to cirrhosis. They also have a higher risk of hepatocellular carcinoma. And not to forget is that they have a very high risk of cardiovascular disease. So left alone, these individuals will advance to cirrhosis. The FIB-4 calculator is included at the bottom, and many electronic medical records, at least in the United States, have this capability already incorporated. Now, why screen people with type 2 diabetes, and why have the guidelines changed by the ADA from just screening those with elevated liver enzymes or steatosis to all people with prediabetes or type 2 diabetes? There are many studies. I will share one that we did here at the University of Florida. And what they show, if you see in the upper left panel, in this study where we screened with elastography 561 patients with type 2 diabetes from outpatient primary care clinics and endocrinology clinics, is that 7 out of 10 people with type 2 diabetes have already steatosis. So it makes little sense to use an ultrasound since the vast majority of people with type 2 diabetes already have steatosis. Instead, our focus should be on assessing the risk of fibrosis, which happens in 1 out of 5 patients with type 2 diabetes. Now, if you were going to rely only on liver enzymes, you have captured only a minority of the patients. Focusing a little bit more on fibrosis, you can see that 15% had at least moderate to advanced fibrosis. This is staggering numbers. More recent studies with MR elastography have shown that about 7% of people have cirrhosis. So it is really important that we focus on screening these individuals. And again, once again, should we have relied on elevated liver enzymes above 40 or even above 30, we would have missed a majority. With that background, I would also like to share with our international community that this observation has been shown in many, many studies have shown this, and have shown that the global prevalence of fibrosis in people with type 2 diabetes is about 12 to 20%, depending on the setting. In this plot with Professor Stefan from Germany, we compared the rate of diabetes, darker red means that you have a higher prevalence of diabetes in that country or region, with that of steatosis and NAFLD. And by no coincidence, people in regions where there is more type 2 diabetes are also exposed to a higher rate and a higher risk of having liver fibrosis. So very important observation worldwide. Now, the tool that we're going to use initially was chosen to be the FIB-4. The FIB-4 is a tool that in reality is aiming to capture, with recent studies showing good specificity, stages 3 and 4. So for non-hepatologists, this might be a relatively new piece of information. But if you go to your phone web browser and type in FIB-4 calculator, you will come up with an equation. Like in this case, you had a 53-year-old patient with AST of 51, ALT of 65, platelets of 151,000. You get a number of 2.2. How do we interpret that number? Well, what we have known from many studies is that if you have a FIB-4 below 1.3, your chances of having advanced fibrosis, this is stages 3 or 4, is fairly low. However, if it's above 2.67, the chances are pretty high. The issue is that in a population of people with type 2 diabetes, about a third are going to fall into this indeterminate category. These are indeterminate for advanced fibrosis, but they are likely to have advanced liver disease and NASH and should be further worked up. So remember, this is particularly important in diabetes as the risk, particularly if they're obese, is very high. Therefore, the additional screening recommendations are that to think that if people that you are seeing have prediabetes or type 2 diabetes, but have persistently elevated liver enzymes, there might be other causes for this. So if these enzymes have been elevated for 6 months or over, and there is a low suspicion for fibrosis based on the FIB-4 index, it should be evaluated for other causes of liver disease. Now, it is important that as clinicians, non-hepatologists know when to refer to the specialist. So any adult with prediabetes or type 2 diabetes with an indeterminate or high FIB-4 index based on the cutoff that I just mentioned to you should have additional risk stratification. And we are recommending, the American Diabetes Association is recommending either a liver stiffness measurement by vibration, by transient control, transient elastography, or by a blood marker that has been well validated in many studies across the world, which is the enhanced liver fibrosis test, which is a commercially available test in many countries. Depending on your setting, primary care doctor, the endocrinologist can do that before referring the patient to the hepatologist. In other cases, endocrinologists or primary care doctors or other specialties may refer the hepatologist for this additional workup. Now, the American Diabetes Association in 2023 had moved to update the guidelines following a fairly well-established algorithm that had been adopted by the American Association of Clinical Endocrinologists and by the liver societies. Again, to summarize what we were talked about, the first test is the FIB-4. Now, it should be, let me share with you some caveats of the FIB-4. It has not been well validated below age 35 and definitely not in youngsters or teenagers. So given that the age is very low, it can give you a falsely low value. And it is also, this observation is true for older individuals where the age can have a disproportionate impact. So above age 65, you may want to consider higher cutoffs. The second factor to remember is that the FIB-4 has good specificity. It means that if the number is high, you probably have really advanced fibrosis. But the sensitivity is low. It means it's not a test that will capture all individuals, particularly in the gray zone. So you need to have clinical judgment in pursuing additional testing. Now, if we think our patient has an indeterminate or risk, you can, again, repeat the transient elastography testing or the ELF test. And definitely if they have a high risk with a high number, probably you could send them directly to the hepatologist. Now, two other things to remember is we need to do all of this within a multidisciplinary team. So we are going to refer our patient to the gastroenterologist or hepatologist. We're going to work together to manage this person in the long term. And how are we going to manage our patients? Well, Here are the recommendations. So people with prediabetes or type 2 diabetes, again, particularly if they're overweight or obese with cardiovascular risk factors, we need to recommend lifestyle changes that promote weight loss, ideally within structured programs that are more effective for weight loss and increasing physical activity. A second aspect, which is more important for many patients with more severe obesity, is to consider using GLP-1 receptor agonists with demonstrated benefits in people with presumable NASH. And we're going to talk about that in a moment. And if you have diabetes, we can use drugs that have been approved for the treatment of diabetes. We're talking when we say diabetes of type 2 diabetes, such as pioglitazone or GLP-1 receptor agonists that have shown to be effective for weight loss. And I would have to mention that 2 GLP-1 receptor agonists have been better studied in NASH with paired biopsy randomized controlled trials, which are liraglutide and semaglutide. And I'm just going to share briefly the data that we have with pioglitazone, which is a thiazolidinedione with a predominantly PPAR gamma action. Maybe some studies suggest also a PPAR alpha effect. We did the first study about 15 years ago, which was in people with prediabetes or type 2 diabetes. And this was followed by studies in people without diabetes and a long-term study that we did that was with up to 3 years of follow-up in people with prediabetes or diabetes, showing fairly consistent results in which depending on the histological definition, between 1/3 to 2/3 of patients had a reversal of steatohepatitis. And this is followed by studies combining with vitamin E, although the results were mixed, and a study from Asia with also positive results. Getting back to the final recommendations, in adults with type 2 diabetes and NASH, the use of glucose-lowering therapies other than pioglitazone or GLP-1 may be continued, but they don't have efficacy in NASH. I'm often asked if metformin can help. Metformin is a great drug to treat diabetes and lower glucose, but has no major effect in NASH. And I have to mention here that we have no FDA-approved drug. So these indications are to treat either obesity or to treat type 2 diabetes within the context of people with NASH. Finally, insulin is a preferred therapy for the treatment of hyperglycemia if you have decompensated cirrhosis, because other agents are not safe. And in this review that I was able to do with Dr. Castera from Paris, France, we summarize how these different drugs work in the diabetes for people with diabetes, what is their expected glucose lowering. But fortunately, only pioglitazone and GLP-1 receptor agonists have been carefully studied with paired biopsies in randomized controlled trials with benefit. But I'd have to mention that SGLT2 inhibitors and insulin can reduce steatosis, but await studies on histology. Taken together, if you have decompensated cirrhosis, you may want to avoid agents that are not insulin and use it with caution because people with cirrhosis are more prone to hypoglycemia. So remember that the entire effort of risk stratification is to identify people before they have cirrhosis, because our ability to reverse cirrhosis is very, very limited. But remember that at any stage, lifestyle interventions and bariatric surgery is recommended, and I will share with you the last recommendation by the ADA in a minute. GLP-1 receptor agonists, and here are the doses for obesity and the doses for diabetes of liraglutide and semaglutide, and the benefit of pioglitazone, which is a generic, very inexpensive drug, but that has some risk of weight gain. And it is important to know that it is an option for your patients. I would like to bring to attention that the American Diabetes Association and the European Association for the Study of Diabetes have also in the text recommended the use of diabetes medications with efficacy in NASH, such as pioglitazone and GLP-1 receptor agonists, and hopefully they will be incorporated in the overall table that I showed you. To finish, remember that people with NASH are at a high risk of cardiovascular disease. That's why please continue the statin in your patients. And that's what the American Diabetes Association wants you to do. Statins are safe for people with diabetes and compensated cirrhosis. So one common mistake I see in primary care is because of elevated liver enzyme, the statins are stopped. We should not do that because they're fairly safe and have actually a number of benefits, hepatocyte function, but they should be used with caution as you approach more advanced liver disease, and they should probably be discontinued in the final stages of advanced liver cirrhosis. Finally, I mentioned to you bariatric surgery. The American Diabetes Association considers metabolic surgery to be appropriate to be done in centers that have experience with these kind of complex procedures because it reduces cardiovascular disease and can reverse NASH, but again, should be used with caution with people with compensated cirrhosis, and it's not recommended in people with decompensated cirrhosis because it has been shown to increase morbidity and mortality in this population. So I want to thank you for your time. And I hope primary care doctors, endocrinologists, cardiologists, everybody who sees these complex patients together with hepatologists and gastroenterologists will work together to put NAFLD at the center of care. As you know, this disease impacts all aspects of our care of people with obesity and diabetes, and it is in our hands to change their destiny and avoid them from developing cirrhosis or hepatocellular carcinoma or cardiovascular disease. Thank you for your time.